Welcome to day 3 of the cardiovascular system. This is the heart valves, blood supply and pathway through the heart topic. So to start with here, we need you guys to ensure that you have the Human Body and Health and Illness Study Guide, page 172 through 173, questions 1 to 26 done. Today we are going to go over the content from yesterday's reading assignment, which was page 288 through 293 in the Human Body and Health and Illness textbook, the old one. Now the diagrams, again, are back up here. We're going to continue on with those diagrams we looked at yesterday. So page 288, we're going to start looking at the heart valves. The valves themselves we've already talked about in the right atrium, between the right atrium ventricle, between the right ventricle and the pulmonary circulation, as well as the left atrium ventricle and the aortic circulation, the systemic circulation, the aortic valve. Essentially, there's two different types of valves. This is on page 288 of your textbook. There are atrioventricular valves, or AV valves. They are located between the atria and the ventricles. They are also considered cuspid valves. These cuspid valves are, if you were to take a rubber glove and cut the tip off the finger in a couple of slots, one on either side, you would make a reasonable model of the bicuspid, bi meaning two. Bicuspid is in the left side of the heart. Now, some parallels here between the heart structure and the rest of our body. If you think about the lobes of lung that we have 2 lobes of lung on our left side and 3 on our right. If we look at the cuspid valves, we have 2 flaps, or bicuspid, on the left, and 3 flaps, or tricuspid, on the right. So 3 lobes of lung on the right side of our body and 3 little flaps that make up the tricuspid valve. Now, another name for the bicuspid is what's also called the mitral valve. It resembles a bishop's mitre, and the mitre is that little hat that bishops wear in the Catholic Church, and there's those 2 little flaps. Remember, there's a term called chordae tendineae. That's these small little tendons that hold the flaps pointing towards the direction of the blood flow. Now, these are not muscular controlled. These are controlled by the presence of pressure on either one side or the other of the flaps. If there is more pressure on the atrial side, blood flows through those atrioventricular valves. It stretches, the blood flow moving into the ventricles allows the ventricles to stretch. As the ventricle starts its cycle, where it contracts, it puts a backward force on these flaps, and they collapse upon themselves to cut off the blood flow going back up into the atria, or what's called retrograde flow. It cuts off that circulation, and it forces that blood up through the semilunar valves. The pulmonary semilunar valve up here going to the pulmonary circulation, and the aortic semilunar valve here going out to the aorta from the left ventricle. Okay, so the looking on page 289, depending on your specialty, cardiologists can place their stethoscope in different parts of the body and actually listen to each one of the valves to find out if there's a valvular obstruction or a valvular issue. If a person has an issue developing with heart valves, it will sometimes manifest itself with specific sounds. At this level, we're not going to get into that, but the term, trying to remember the term here, retrograde flow or reverse flow will happen in a valve that has been stenotic or narrowed. Sometimes the valves don't open completely, or they're also referred to as incompetent. If a valve is not working properly, it can also be referred to as an incompetent valve. So anyways, moving right along here, everybody should remember that moving into the right atrium, you're going through the tricuspid, into the right ventricle, out of the right ventricle through the pulmonary semilunar, into the left aorta, into the left atrium, through the atrium, into the left ventricle through the bicuspid valve or the mitral valve, out of the left ventricle through the aortic semilunar valve. Okay, page 289. The term stenosis, okay, or a stenotic valve means that it is narrowed. So it makes it difficult for the heart chamber to force blood through the valve, causing an increase in work to that pumping chamber and causing an enlargement of that muscle. Now, the myocardium, the middle muscle layer of that heart, is no different than skeletal muscle. If you work it very, very hard, it will become hypertrophed. Bodybuilders try to encourage skeletal muscle hypertrophy by working out very, very hard, by straining and stretching the muscles, and the muscle will repair itself and get larger. This might seem to be a good thing with the heart, but it's not. A heart that is cardiovascularly fit is not overly large. A heart that is, if we exercise our heart, make it work hard periodically, it will become cardiovascularly fit. If we are working our heart constantly hard, okay, as in a situation where we have a narrowed valve or we have atherosclerotic buildup within our arterial circulation and it builds up a back pressure that the ventricle has to overcome, okay, that makes the ventricles work hard all the time, and then it becomes hypertrophed, gets enlarged. As it becomes enlarged, it can no longer allow the same volume of blood into it. It can't stretch to accommodate the blood flow, and it becomes less efficient. It's like a big bodybuilder can't even reach in to scratch his nose because his biceps are too muscle bound, and his movement is restricted. The heart becomes that way as well. Its efficiency drops off rapidly as it becomes hypertrophic, and that compounds the problem in that it has to work even harder to establish or to get the minimum amount of blood flow out, so it becomes even more hypertrophed, and then we re-enter the whole cycle of heart failure, which is something we'll talk about in a little while here. Now, when we look at the bottom of page 289, we talk about some heart sounds. The heart sounds essentially are described as a lub and dub. If you're listening to your heart with a stethoscope, you hear a lub dup, lub dup, lub dup. And essentially, those are due to the closure of valves. Nothing else in the heart really makes a lot of noise besides the flow of the blood and the heart valves closing. Now, the first sound is called the LUP, and it's called S1. Okay, S1 is due to the closure of the atrioventricular valves at the beginning of the ventricular contraction. Now, blood is flowing into the heart. As the ventricles begin to contract, they're pushing back on the atrioventricular valves, so they snap shut. As the ventricles continue their contraction, they force blood out of the semilunar valves, which open without a sound. And then as they relax, the semilunar valves snap shut to prevent blood flowing back from the aorta into the left ventricle and from the pulmonary artery into the right ventricle. And that snapping shut of the semilunar valves is what's called the DUP, or S2. And the cycle continues. As the ventricles relax, they allow blood to flow in from the atria and the pulmonary veins and so on, and it fills up the ventricle. The semilunar valves are now closed. The atrioventricular valves open to allow this blood to flow in. Then the ventricles contract again, and the whole cycle continues with the lubbed up, lubbed up. Now, different sounds, other sounds can happen at the same time. These extra sounds are due to vibrations caused by the rapid flow of blood into the ventricles. The extra sounds are called S3 and 4. When both S3 and 4 occur, what's called a gallop rhythm can be heard. Or the valves may not close completely at the same time. So instead of a lubbed up, you might get a lubbed up, lubbed up, lubbed up, where you hear two distinct valve closures. My wife's heart sounds a lot like that. It has a little bit of a distinctive sound to it. Anyways, page 290, looking at pathway of blood flow through the heart. Now there's a good flow diagram there on page 290, and it follows the exact same pathway that I gave you guys when we were looking at the different structures of the heart, the different great vessels and structures. If you remember yesterday's content, it's going to be exactly the same as what we're going to do right away here. Basically, starting at the right atrium once again. The right atrium is fed by the superior vena cava and the inferior vena cava. So we look at the right atrium, that's where we start off. That right atrium goes through the tricuspid valve, three little flappy doodles, the atrioventricular valve, into the right ventricle. The right ventricle then squeezes that blood out the pulmonic semilunar valve, or the pulmonary semilunar valve. This is also called just the plain old pulmonic valve. Out into the pulmonary artery, the main one here, and they're dividing it up into pulmonary artery main and then pulmonary arteries right and left. Then the pulmonary capillaries within the lungs, Then the 4 pulmonary veins from the right and the left, culminating into the left atrium through the bicuspid valve, atrioventricular valve that just has 2 little flaps, into the left ventricle, which is the strongest, the most muscular of the chambers, through the aortic semilunar valve into the aorta for distribution out to the systemic circulation. This would flow out to arteries, arterioles, systemic capillaries, veins, or venules, sorry, veins, and then the inferior and superior vena cava. Now, whoops and detours. Normally blood flows through 4 separate chambers from the right side of the heart to the lungs and back to the left side of the heart. Congenital heart defects sometimes occur in small children. Everybody has heard of a child being born with a heart defect where they have had to have surgery and so on. Well, these are defects that are present in everyone up until a certain developmental stage. Most infants will rectify this prior to being born, but if the defect or the pathway has not completely fused up, infants may be in a little bit of trouble, so they have to surgically repair them. Now, the right and left hearts are separated by what's called an interatrial and intraventricular septum. Now, a septum is a piece of tissue like that little spot between your left and right nostril. That little strip of tissue is called a septum. Okay. Now, the septum, this is the intraventricular septum right here. This muscular part between the right ventricle and left ventricle. Now, if you think about when a baby is in utero, it does not need to force blood out to the lungs into the pulmonary circulation for oxygenation. It receives its oxygen-rich blood directly from the umbilical circulation and the placenta, where the mother's blood flow transfers it across the womb into the placenta, then into the baby. So to force blood out to the lungs is really unnecessary. As the lungs are developing and maturing, they have active blood flow, but they don't need to reoxygenate it. So there is a hole between the right ventricle and the left ventricle. So blood coming into the right atrium, goes to the right atrium, right ventricle, through to the left ventricle, and out to the systemic circulation, okay? And rather than being forced out to the lungs. As the baby becomes full term, this intraventricular septal pathway closes over. If the baby has fully developed and that pathway closes over, there's no issues. However, if they have a congenital heart defect, as it's termed, they may have one of a number of different issues. If they have flow from the right side of the heart into the left ventricle and out to systemic circulation without being forced out through the pulmonary circulation, once that baby is born, they are not able to oxygenate adequately the amount of blood flowing through their body. So this right to left shunt, okay, right to left shunt creates a situation that is life-threatening because the baby is essentially hypoxic. Hypoxic meaning low in oxygen. They will be bluish. They will not color up nicely. It'll be nice and pink because their heart is pumping blood not through the pulmonary circulation to the lungs, but out through the systemic circulation without adequate flow to the lungs. Now, if there is a flow out to the lungs and then back to the left side of the heart and then across to the right side of the heart again, which is sometimes what happens, a left to right shunt, the body is circulating blood out to the lungs after it's been reoxygenated already, which is unnecessary. So rather than putting all of the blood that was reoxygenated out to the systemic circulation, the body, their little hearts are pushing it back to the right side because of the way that that septal defect is formed and reoxygenating that blood that's already been reoxygenated. So there's 2 different shunts, right to left and left to right. The left to right could be illustrated by a child with a hole in the septum, pushing blood from the left side to the right side. The child will not be cyanotic, they won't be bluish, but because the left ventricle is pumping oxygenated blood, a VSD, okay, ventricular septal defect, is described as a left to right shunt that is acyanotic. So it's not absolutely life-threatening at this point. They have time, they can get in there and fix that and it's done. The right to left shunt, however, they will be cyanotic. A lot of times they will have a stenotic pulmonary valve. So this valve here going out to the lungs will be narrowed, won't be fully developed. So the blood encounters resistance, and it forces its way through that septum back over to the left side without being reoxygenated. This right to left shunt contains unoxygenated blood, and the patient will appear cyanotic and lethargic, meaning that they're not getting enough oxygen. They are oxygen poor and bluish. That's the term cyanotic means, having a cyan shade to their skin. Now, when we move on to the next little section here, past the valves and everything, we move on to one of the most important circulations, besides the ones to our brain, that we have. This is the blood supply to the myocardium, or the coronary arteries. These are the arteries that have a massive blood flow through them, and they are responsible for delivering oxygenated blood to the myocardial tissues themselves. Now, these are very subject to atherosclerotic buildup. You've heard the term "you are what you eat." It is absolutely true when it comes to fatty foods. The more fatty foods and cholesterol-rich foods we put in our mouths, the more buildup we have in our arteries. Similar to having hard water build up calcium and other minerals on the inside of our hoses and our taps, and depositing iron on so on our toilets and everything, discoloring them. The same thing happens in our arteries if we don't take care of our body. This fatty buildup can create a layer, and I don't think I've got an image on here, but you can see a layer of plaque on page 292 of your textbook. The arteries build up layers of fat, and that decreases the lumen, or the pathway through that artery. It decreases the amount of blood that can flow through it. There are really, really good videos online of interventions, what are called angioplasty and angiography and angioplasty, where they'll actually go in and they'll watch they'll put a dye in, and they'll watch how good the blood flow is. They'll go in with a balloon and insert it into an artery, and they'll inflate the balloon to stretch it out, and then they'll show the reestablished blood flow to the heart. I'll put some links up on day 3 so you can see the balloon angiography and the balloon angioplasty. So next is the coronary arteries. We have 2 main coronary arteries. They are the left and the right coronary arteries, and of course they emanate from the aorta just about immediately after it exits the left ventricle. The left coronary artery branches into the left anterior descending, and anterior being the front. Okay, the left anterior descending, which is this one right here. Okay, it's blue. The left anterior descending. I want to make sure I'm doing these ones right. Yep, and the red ones here. I said it was blue, but it's supposed to be red. The left anterior descending is right here. And then there is the circumflex. And the circumflex goes around the artery, around to the back side of the left side here. Okay, so we have the left anterior descending, dropping straight down, and you can see the circumflex disappearing over to the side and coming around over here to nourish the posterior of the left side of the heart. Now the right coronary artery comes out and nourishes the right side. You see it descends down across here, sending branches down the front of the right side of the heart, and it circles around and also assists with oxygenation of the rear of the right side of the heart as well. Now, just like we have veins throughout our other circulation in the system, we have coronary veins that carry the blood back to the superior vena cava, where it's returned into the blood flow. Now, the coronary veins carry the blood back to the coronary sinus right here, and that dumps into the superior vena cava. Coronary blood flow is greatest during myocardial relaxation. Now, if you think about it, this is a big muscle. If it squeezes because it's contracting, it gets hard. It also stretches and squeezes the blood out of the arteries and veins, so there's not a lot of active blood flow. When it relaxes, the tissues are relaxed, and there's active blood flow throughout the veins and arteries of the coronary artery. Now, the coronary artery blood flow also has a couple of other characteristics. It can increase drastically. At rest right now, your blood flow through the coronary arteries and veins is the necessary volume. Depending on your cardiovascular fitness level, you can increase that volume 4 to 5 times the normal heart volume rate. Coronary arteries that have severe fatty buildup and plaque usually are maximally dilated already, and if we put extra stress on the heart, that can cause a blockage, or a piece of this fatty plaque can break off, cause an occlusion or a plugging off of the coronary artery, and cause what's called a myocardial infarction. An infarct is a death of heart tissue. The heart muscle will die if it's cut off from blood circulation, just like any other tissue in our body. It is very susceptible to that low oxygen level, and a heart attack is characterized by what's called ischemic chest pain. And ischemic chest pain is the heart muscle being low on oxygen and giving a distinctive, characteristic crushing chest pain that emanates up the left side of the neck, into the jaw, down the left arm. That's characteristic for a male. Sometimes females will find an achy back, a backache between the shoulder blades, may be their ischemic chest pain as well. If not taken care of early, an infarct means an actual death of the tissues because of a lack of blood flow. A myocardial infarction is kind of a technical name for the end result of a heart attack. If coronary blood flow diminishes, the myocardium experiences oxygen deprivation, and that oxygen deprivation is called ischemia. That ischemia will lead to that anginal chest pain, or ischemic chest pain that I was just talking about, and it can also lead to myocardial infarction. When an infarct happens, the cells can, as they die, they will rupture and they will leak out enzymes into the circulation. These enzymes on page 293 are really, we don't really need to know a whole lot about them for the EMR level program, but knowing what they are is handy as well. There's a number of different plasma levels, and plasma basically means that one of the components of your blood. They will do a blood test. They're looking for what's called a creatinine phosphokinase, aminotransferase, and lactic dehydrogenase, okay, or also called troponins. A regulator of myocardial protein, called troponins, also leaks out, and plasma elevations of CPK, AST, LDH, and troponin are indicators of a myocardial infarction. Over a period of time, they will elevate and then they will decrease. So levels of these hormones within the circulatory system will give an indication of how long ago the individual had the myocardial infarction and to what extent the infarct has taken place. Now, we're going to stop there. We're going to go into cardiac conduction system tomorrow. That's where we're going to look at the sinoatrial, atrioventricular, and bundle of His, Purkinje fibers, et cetera, et cetera. So right now, if you guys have a look at your day 3 course schedule, okay? Your assignment is to have a look at your study guide, page 173 through 175. That's the old one. If you're using the new study guide, page 130, 131, 132. I'd like you also to have a look at the rest of page 293 up to through to 296. We're going to look at the cardiac conduction system, automaticity and rhythmicity, which are the characteristics or some of the features of the heart. And page 296 is the end of this anatomy of the heart chapter. So we're going to blast this one off tomorrow and then move on to the vocab quiz and heart anatomy quiz on day 5. Have a good day, guys. Work hard.